My name is Elyse Johnston. I'm a faculty member at the VA Pittsburgh Healthcare System, along with the University of Pittsburgh Medical Center. Today I'm going to talk about our study that was recently published in GIE, entitled The Risk of Bacterial Exposure to the Endoscopist's Face During Endoscopy. I want to first thank my mentor, Dr. Asif Khalid. I also want to thank Dr. Nadia Habibin and the microbiology lab at VA Pittsburgh. So why do we do this study? Well, we observed great variability in the use of facial protection by endoscopists, ranging anywhere from no facial protection to simple eyeglasses to full face shields. We also had heard anecdotal reports of recognized facial splashes during endoscopy. This really prompted us to review the guidelines as well as the data regarding exposure during endoscopy. So what we found was that the ASG guidelines recommended that individual units develop policies based on OSHA as well as state-mandated recommendations regarding the use of facial or eye protection during endoscopy, and that there was a paucity of data regarding the risk of exposure, with the only data really being extrapolated from surgical procedures and the risk of splashes as identified by blood. So ultimately, this has led to a significant amount of variability in clinical practice, with really institutional culture dictating the use of facial personal protective equipment. So what did we first do? Well, we started by conducting a survey of practice patterns of facial protection of the providers at our primary site, the VA hospital, as well as the two academic hospitals affiliated with the University of Pittsburgh Medical Center. The survey included both fellow as well as attending gastroenterologists. And what we found was that the majority of providers had experienced recognized facial splash during endoscopy, but that the majority did not wear any facial protection. As one would expect, we also found that there was a greater willingness to change practice patterns in the fellow cohort compared to the more experienced attending cohort. From here, we embarked on a 6-month prospective study that was done at the VA hospital, with our primary aim being to calculate the rate of endoscopic facial exposure during endoscopy, as indicated by face shield bacterial cultures. So in developing the study, we really had no basis for what an exposure rate would be, how to define exposure, the background rate of bacterial colonization of the face shields as they were not sterile, and what growth would be attributed to the endoscopy versus other environmental factors, especially being in a hospital setting. Because of this, we designed a study to have multiple groups and controls. So essentially we had 4 different groups. The first one being the facial worn by the endoscopist. It was cultured pre-use and after use. And pretty much the endoscopist wore for the entire duration of the AM procedure block, which included multiple different endoscopy procedures. The second group involved placing a face shield within the endoscopy suite, but about 5 to 6 feet away from the patient, with the external surface of the face shield facing the patient. The third group was a negative control, in which you actually place a face shield in the intake bay, removed from the exposures that would be attributed to the endoscopic procedures, but also within a patient care area. The fourth group was a negative control or a positive control group, in which we actually deliberately contaminated a face shield with a colonoscope after use. And this was really to make sure that we could get a baseline CFU count or colony forming unit count for definitive exposure, and to make sure that our method allowed us to detect bacterial CFU count. So all the swabs were cultured for 48 hours, and the growth was reported as no growth or by colony forming units. So one may ask us why we use AM blocker procedures versus after each procedure. And this was really done because the rate of exposure was unknown and allowed us to bundle more procedures together. It also allowed us not to interrupt our workflow and allowed less workflow demand on the staff, as well as to decrease our costs. So what did we find? Well, we found a direct correlation of incidence of exposure during endoscopy with decreasing distance to the patient. So essentially, the closer you are, the higher the risk of exposure, with the highest rate obviously being in our group of the positive control group, in which we deliberately contaminated the mask. But we also found a correlation with the endoscopist face shield being a higher rate than the endoscopy suite wall, and then the patient bay area outside of the endoscopy area. So we estimated that the occurrence of unrecognized splash containing bacteria to occur to the endoscopist being 5.6 out of 100 half days of endoscopy, equating to a few exposures to the endoscopist each year. This may be underestimated as we use the higher CFU count to define an exposure to increase our specificity. So what does this mean practically? Well, the highest risk is for the endoscopist, but also there's a risk to other staff in the room, as suggested by the mask that was placed in the endoscopic suite. So why does this matter? Well, from our data, we were really looking at only bacterial CFU count and can't speak to exposure to specific organisms or viruses. Well, we feel this could represent a possible mode of transmission of especially certain types of bacteria we worry about, such as C. diff or multi-drug resistant organisms, to the endoscopist, as well as between patients with the endoscopist as a source, as most of us don't wash our face during endoscopic procedures, but we do touch our face. However, we didn't look at specific organisms, but this could be farther explored in the future. Additionally, we don't know that the exposure to the endoscopist's face equates to mucous membrane exposure. In the future, the clinical significance of this exposure risk could also be farther explored beyond identifying specific types of bacteria, or even evaluating the incidence of illnesses in the endoscopist, such as conjunctivitis, or the rates of colonization on the endoscopist. Ultimately, though, we feel that this study was the first to really quantify the rate of unrecognized exposure to the endoscopist's face to potentially infectious bacterial pathogens, which may result in the transmission of infectious diseases. Because of this, in conclusion, we recommend the use of universal facial protection during GI endoscopy.